next case is a really interesting one of a patient who's used to monovision in their contact lenses, who has had their dominant eye operated and has ended up myopic. So how do we fix this?
Masara, this is a really interesting one, another very interesting one. So this is correcting another surgeon's refractive surprise, but using premium IOLs. So he presented to us pre-operatively. He was myopic, so the right eye was about a minus 425 spherical equivalent, and the left eye was about a minus 5.5. Now, he used to be a successful monovision contact lens wearer, and he was set up with his right eye set for distance vision, and his left eye was set up for near vision, leaving him uncorrected by minus 1.75 diopters. And he managed really well with that for years. So the plan at his other place, seeing the other surgeon, was they would treat the right eye and aim for distance, and at a later date they would treat that left eye, aiming for minus 1.75. So when he came to see us and we checked his visions, that right eye that was meant to be plano, so we're hoping for 6.6 better, was actually 660. 1.0 logmar. He was N4 in that eye, but he didn't want reading in that eye, he wanted distance. And when we refracted him, he was minus 2.75 with a minus 1.25 astigmatism at axis 90. Masara, why do you think patients can end up with this level of myopia post-surgery?
Well, there's a few reasons. The first one is the incorrect power IOL being implanted. Next thing could be just unreliable biometry. So perhaps the eyes were dry, perhaps he'd been wearing contact lenses and maybe that affected the K readings, and that could potentially cause a refractive surprise. Other things include just the effective lens position. So we have complex mathematical calculations to predict where the lens is going to sit in any individual's eye, but sometimes that can be wrong or that can be off in that specific individual. The final thing I would say is the lens being pushed forward in some way, and that could be due to trapped viscoelastic behind the lens, and we call that capsular distension syndrome.
If you have a little look at the biometry, what it does show is there's 1.2 diopters of astigmatism on that biometry, and looking at the refraction, there's also that 1.2 diopters of astigmatism at the correlating axis. So then what I did was then ask for some pentacams for this patient. So I sent the patient back out to have some pentacam reading just to make sure. And actually, as you can see right there, 1.2 diopters of cornea, it matches the biometry, it matches the refraction. So this patient does have a residual astigmatism there, and actually it was a non-toric IOL that was put in that eye. That pentacam, if you have a little look, the corneal thickness is about 450-ish microns. There is some subtle back elevation on the cornea. Masara, would you laser this patient?
Well, I'd want to see a Bell ambrosia display, which tells us whether there's any kind of potential risk of ectasia. But based on that alone, there's no corneal ectasia. So, they are thin, but they are suitable for surface laser. The only thing I would say in these patients is he's in his 70s, so we know that there could be issues with healing. We know that that may be delayed because of his age. We know that the vision may take a couple of months to actually stabilize and settle. So yes, we could potentially get there with surface laser, but will he be happy in the interim? Probably not. So I would be leaning more towards alternative options for this patient.
So this pentacam here just has a look at the left eye as well. So we need to make a plan for that left eye. It's still phakic, and then we know he needs to have a lens aiming for near vision in that left eye. So there are options here. So we could do a contact lens trial. That right eye is set for near, he's got some N4. We could switch the dominant, so we could potentially leave the right eye as it is and just treat that left eye aiming for distance. And the other option obviously is to correct the right eye fully with a contact lens and set the left eye for near, just to make sure that's exactly what he wanted. Now, luckily, this patient had already been to his own contact lens optometrist, or own contact lens optician, and had tried both options out, and he definitely knew he wanted that right eye set for distance and he wanted to set that left eye for reading.
What was ultimately decided was that the patient would have a right Sulcoflex lens implanted to correct that residual myopia. And for the astigmatism, which was around 1.25 diopters, the plan was made to perform limbal relaxing incisions. And there are multiple ways that you could do it. You could implant a toric Sulcoflex lens, which will correct the astigmatism and the myopia, but we know with these lenses there is still that small risk of the lens rotating, and the Sulcoflex lenses are very stable, but there's a small chance. So if it's a small amount of astigmatism, 1.2, 1.25, that's something that's very easily treatable with limbal relaxing incision. So that was a decision that was made for the right eye. In the meantime, the decision was made to do repeated scans on the left eye just to ensure that things were stable before implanting a Rayner EMV lens in the left eye, targeting, as you suggested, minus 1.75 diopters. Now that is a little bit more than recommended by Rayner. Typically they recommend up to 1.5, but you can push a little bit more if we know the patient tolerates it. And the patient did tolerated it really well. So Purvi, you do a lot of our calculations here at OCL Vision. Can you talk us through what you need to do in order to plan the surgery with a Sulcoflex? What kind of measurements are needed for the planning?
Of course, well, the Rayner platform is fantastic for doing calculations, and for this Sulcoflex especially. What I like about this, it shows the different elements that you need. So you need the technician to do fantastic scans, because as we know, any IOL does need those brilliant K readings, the ACD. You also need an optometrist who knows how to refract pretty well, because actually this is refraction dependent. So we input the refraction and your desired outcome, your target refraction, and they tell you exactly what lens you need to put in the eye and at what axis. The outcome of this patient was fantastic. So that right eye, that patient came out 6'4", unaided. The left eye was as planned. They came out N4 at 45 centimeters, but if you have a look at the range of vision they got with that, they got N5 at 30 to 65 centimeters. That's a great range of vision at N5 vision, so that patient was absolutely delighted. And you can tell with the refraction, there was no post-op refractive surprise here. The right eye was spherical equivalent was plus 0.25, and the left eye was -2, so that patient was absolutely delighted, and that's a nice OCT just to show how the Sulcoflex sits in the eye.
That's an excellent case. A really, really interesting way of approaching the case, combining different technologies to give the patient the best outcome.
Definitely.
Thank you.